Okay, good morning. This presentation is on malignant hyperthermia. And the way we're going to understand malignant hyperthermia, if you look on your handout that has the muscle on it. Okay, so you have your arm there, and underneath, right next to it, you see these columns, and those are the myofibrils. Those are the working parts of the muscle. And if you notice, each of the myofibrils are covered by a web-like structure called sarcoplasmic reticulum. The sarcoplasmic reticulum contains calcium. We'll talk about that function in a little bit here. If you look at the myofibrils even more closely, you'll see that they are made of actin and myosin components. And those actin and myosin components are activated when calcium gets released from the sarcoplasmic reticulum. So this curtain is going to represent our sarcoplasmic reticulum that has our calcium in it. And for a normal muscle contraction, we'll have this going to our muscle. An electrical signal comes down to the muscle and stimulates the sarcoplasmic reticulum to release calcium, which makes the muscle work. Work, 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 work. Then shortly thereafter, the calcium gets retaken up by the sarcoplasmic reticulum, and the muscle stops contracting. What is happening to the muscle when it exercises?
Getting heated up.
Okay, very good. Okay, we're producing heat. We're also producing what? More, okay, carbon dioxide. So we're going to produce carbon dioxide. And we're going to consume oxygen. So we're consuming more oxygen. We're producing heat and carbon dioxide. What's happening to our heart rate? Heart rate's going to increase. You're not dead yet. Keep going. So we're going to increase our heart rate. What else increases when we're doing that? Great. Increased breathing. Okay. Now, under even more vigorous conditions, when we release the calcium, more and exaggerated changes happen.
Work hard,
Work.
hard, hard, work,
You're going to have even more oxygen consumption. You're going to have even more increase of heart rate. You're going to have more increase in respiration. You're going to produce more heat, more carbon dioxide, and somebody mentioned earlier, you're going to increase acidosis, okay? In the case of malignant hyperthermia, the sarcoplasmic reticulum is defective, and under the presence of certain trigger agents, which include succinylcholine and inhalation agents, the sarcoplasmic reticulum stays open even longer, and there's even more calcium involved, and even more exaggerated than a vigorous exercise response. The only way to stop this process is, one, we have to remove the trigger agent so that the sarcoplasmic reticulum will start to work more. And then,
after immediately turning off the anesthetic gases, you may use these orange filters to further remove any other trace gases from the anesthesia system. They come with instructions on them, and they're well worth reviewing ahead of time prior to having a malignant hyperthermia crisis. The instructions are as follows. First, turn off the anesthesia vaporizer. Next, increase fresh gas flow to greater than 10 liters per minute for at least 90 seconds to flush the vapor from the anesthesia delivery system. Place one of the vapor clean canisters on the inspired port of the anesthesia machine and the other canister on the expired port of the anesthesia machine. And 4, replace the breathing bag and connect new breathing circuit between the patient and the vapor clean canisters. Maintain fresh gas flow at least 3 liters per minute.
and then we stabilize the sarcoplasmic reticulum with either Ionodex or Dantrin. And hopefully this will help stop the process and resorb the calcium and save our patient. So what are we going to do about our increased oxygen consumption? Yeah, provide more oxygen for him. What are we going to do about the carbon dioxide production? If they're on a ventilator, we're going to ventilate them more. In addition, the soda lime on the anesthesia machine, that may get used up. So what we want to do is replace our soda lime so we can also get rid of carbon dioxide there. And then if we have some acidosis, what are we going to do there? Bicarb. Very good. Now what do we do about the heat? Ice. Pack ice in certain areas. You can also put cold water in the Foley. Do you have the Foley with cold water for Robbie? You can put down an NG tube and put cold water down that and do cold water lavages that way. Before they invented the Dantrium, which came before the Ranodex, all they had was packing the patient in ice, and by some miracle, some patients still survive. But during this whole process, we have released a silent killer.
Who is this mystery killer?
What have we released that we haven't treated that is most likely going to kill the patient during this time? Potassium. Yes, it's potassium. Go ahead, open up the envelope. Potassium. You win the award. Now, what happens is, the reason there's a lot of potassium released is that the acidosis we talked about goes into the muscle cells and pushes a lot of potassium into the bloodstream. In addition, another way that lots of potassium is released is that the muscle cells, under vigorous contraction, will break open and release even more potassium. So we have a lot of potassium swimming around in this patient, and that we need to get rid of before it essentially affects the heart and causes cardiac arrest.
Early signs of this hidden killer attacking our patient can be found on the EKG. Early on, you'll first see peak T waves, but as the potassium increases, the P waves are going to flatten and you're going to see a prolonged PR, giving you more urgent notice that hyperkalemia needs to be treated. When you get to bradycardia, it is extremely severe. As you remember, malignant hyperthermia is a disease that causes a hypermetabolic rate with increased heart rate and increased respirations to meet metabolic needs. Therefore, if bradycardia occurs, the cardiac output is not going to meet the metabolic needs of the body, and therefore the patient is going to be placed in even a more critical situation. And that is why potassium is the #1 killer of people during malignant hyperthermia.
We've treated all these other things, but now we have to treat the potassium. So how do we treat the potassium? What's this for?
Sodium bicarb.
There you go. Why is this sodium bicarb?
Looks like it's gonna keep the dick out of
Okay. So one way to remember to get rid of our killer is we're going to attack him with the hammer with sodium bicarb. Okay.
We will use the bicarb to pull the acid ion out of the cell. This will cause the potassium to go back into the cell, out of the bloodstream.
Okay, that's our first line of treatment. Well, going with this, whose hammer is this?
That's Thor.
Thor's hammer. Okay. There are 3 forms of Thor. If you read the comic book, it's not in the movie. What form does Thor take during when he's not Thor in the comic book? Dr. Donald Blake. So Dr. Donald Blake, he's going to use his medical intellect, and he's going to do what Brandon suggested, and he's going to inject glucose and insulin. And the way glucose and insulin work is the glucose combines with the potassium under the influence of insulin and drives the potassium back into the cell. So Dr. Donald Blake, first we have Thor's hammer, baking soda. Next we have glucose and insulin to treat the high potassium. Yeah, and then if you get very life-threatening arrhythmias in emergencies, there's one more treatment we need to consider emergently, with the third form of Thor, and that's with this. This is for caveman Thor. And what would that agent be? Calcium, exactly. Even though this is a disease of excess release of calcium, the way to emergently reverse the cardiotoxic effects of calcium in an emergency situation is with calcium. So again, to summarize, what are we going to do to treat malignant hyperthermia?
First, we're going to stop the MH process by removing trigger agents, which are succinylcholine and the volatile anesthetics. Next, we're going to stabilize the sarcoplasmic reticulum with either Ionodex, Dantrium, or Rivanto. Next, we're going to treat the problems that come from a vigorously working muscle that has gone wild and out of control. Because there's increased oxygen consumption, we simply treat this with increasing the oxygen supply. For increased carbon dioxide production, we need to get rid of this if the patient's on a ventilator by increasing their ventilation. In an anesthesia machine, we may need to change the soda line, which may get used up in the course of a malignant hyperthermia event. For the increased temperature, we will cool the patient with ice packs and lavages. For the acidosis, we'll use bicarb and increased ventilation. Next, we need to be on the lookout for the hidden killer potassium and treat or combat it with the three forms of Thor: bicarb, insulin and glucose, and then if there are life-threatening arrhythmias, we need to use calcium gluconate or calcium chloride to stabilize the heart membrane. Later on, we need to look for myoglobinuria. The myoglobin comes from the ruptured muscle cells during the violent malignant hyperthermia crisis. We treat this by alkalinizing the urine with intravenous bicarb to prevent the clogging of the kidneys. Malignant hyperthermia patients may also develop DIC, a problem with excessive bleeding. Since the patient may have a recurrence of their malignant hyperthermia, and because the patient might develop later problems of DIC or myoglobinemia, it is best to put the patient in the intensive care unit for observation after a crisis.
And that's malignant hyperthermia, an excessive muscle gone wild.
So before you have a test in there, you know we don't use, because we don't use Dentalate anymore, we're using Ranadex. And I'm going to give you a copy of the, it's a color copy on our MH cart. On the back, you're going to find the sizes, pounds per kilogram. So I want you to take one and pass it around. It also is a colored version on the MH cart. I want you to know the MH crisis is characterized by all of the following, but which ones? Neuroleptic malignant syndrome, because we talked about hypothermia, hypometabolism, and sustained muscle contractions because we saw the muscle working. And it always acts, MH is most often found in children and young adults. Each bottle of Ranadex is reconstituted with 5 ml, so you're going to find one bottle of Ranadex in the MH cart, and you're going to find a 10 cc syringe. You're going to mix it with 5 ml of preservative-free sterile water. Preservative-free sterile water. And what is the first step that team should take in the MH crisis? You saw it up here. Stop the triggering agents is the first thing. And he talked about applying ice. Where would you apply ice? In the axilla, the groin, and the neck. Okay, and then early signs. This tachypnea, the elevated CO2, the increased O2 consumption, and we talked about that. Dark colored urine and muscle rigidity. You are not going to have the hyperkalemia just yet as a first sign. You will have it as a sign, but not a first sign. And you will have DIC, but not later. So if you get a chance, for the last in-service, we actually cracked open the MH cart. But the MH cart is labeled now, so that you can see where the Ranadex is and become familiar with it. If we have to use more than one vial, then our pharmacy will mix the dantrolene. for us, which is a big, huge thing. And if you look on your paper, you'll see where you have to mix the Ranadex. You shake it for about 10 seconds, and you should see what color on your sheet. I just gave it to you. Orange. That ends our in-service on MH. Any questions? Everybody good? Thank you for showing up and participating. Yep.